thyroid. So don't forget, thyroid regulation is going to start in the hypothalamus, right? Thyrotropic releasing hormone is going to go to thyroid stimulating hormone, which is where again? Did I give you the notes? You got the notes. Anterior pituitary, thyroid stimulating hormone then goes to the thyroid. We know the thyroid is going to be on the trachea, on the anterior of the trachea, right? There's right and left lobe and an isthmus, which connects them together. There can also be what's called a pyramidal lobe, which is this kind of third little lobe that can stick up from your isthmus. It looks like a little finger, almost like a little pinky sticking up from there. It's inconsequential. You know, it doesn't have any bearing on it. Okay. On the back parts, those parathyroid glands that we talked about before. Now, we need to talk about the microscopic, and I have pictures for you. So if we were to take a microscope and to look at the inside of the thyroid, this is what we would see, okay, on this next slide. So I'm going to explain to you, do I have, did I not put that? Okay, well, okay. So here's macroscopic, the two lobes connected by an isthmus. If you were to make that little point like longer, like little pinky, that would be what the pyramidal lobe looks like. Don't worry about it, that's just inconsequential. Okay, so now we're looking at microscopic, because I know you guys really love microscopic stuff, right? Okay, we've got this smooth area in the center, which is called colloid, C-O-L-L-O-I-D. Okay, colloid. The cell, see those squarish looking cells with the round nuclei just surrounding it? Those are called follicular cells, F-O-L-L-I-C-U-L-A-R. Okay, so the colloid is the smooth, the follicular cells are the cells that touch it. And we need to have this closeness because the two of them, through a very complex series of processes, create T3 and T4. We'll talk about T3 and T4 and specificities in a slide or two, okay? Now, that colloid and those cells that surround it sort of send this T3, T4 back and forth and combine it with a series of structures, okay? Iodine, we've got thyroglobulin, we're going to talk about all of this, okay, to create it. So if we don't have enough iodine, guys, I wanted to show you this picture because I think it's important. What can happen is this colloid can overwork and start to expand. And that's where we get that goiter. Can you imagine all these little follicles doubling in size, right? What would happen to your thyroid gland? It would double in size, okay? And that's sort of where this happens. We also have, if you can see, see the two major ones right in the center, and there's a little triangle underneath them. Are you with me? Let me see if I can get people oh, there we go. No. What? I'm sorry, people at home. I'm trying to get you on. I just got to draw it. Okay. But they changed the camera settings. Okay. So if you're looking at that picture, and you've got two of those circles of colloid. Okay, that smooth stuff. And then you've got all, those square cells that are all the way around with the little round nuclei, right? This is where, between these two areas, this is where we're going to make T3, T4. Are you with me? Okay. What I want to point out is there's little sections between them of clumps of cells that are not touching the colloid. That's the thing. Little clumps of cells that are not touching the colloid. This is where we make a substance called calcitonin. Okay, this is further on in the notes, but I just want to point it out since we're looking at this now. So not only does the thyroid release T3, T4, it releases calcitonin. Calcitonin puts calcium in the bone. It's so stupid, but it's how I always remembered it. Calcitonin is the hormone that puts calcium in the bone. Okay. And then on the back of the thyroid, we have those parathyroid glands, and this is in the notes, we're going to get to it, that releases parathyroid or parathyroid hormone. Parathyroid hormone is going to take calcium out of the bone. Okay, so these two hormones are going to regulate the deposition or the removal of calcium from the bone. Now, why would we want to do that? Why do we want to pull, don't we want calcium in the bone? If your calcium is running low, we're going to pull it out. Well, what else are we going to use calcium for in the body? We use it to harden bones and mineralize bone as calcium phosphate, but we're going to release it for what important physiological function? Nobody? It helps muscle contract. It helps muscle contract. Okay, so don't forget that we're going to need appropriate serum levels of calcium, because what do we care more about, the structure of our bones or our heart beating, which is going to be calcium is very important. The heart beating. That's why we get osteoporosis. I think we think that calcium should be deposited in the bones first. It's not. That's great. It makes them hard, but it's a reservoir in order for us to tap into it, to use that calcium as an electrolyte to help physiological functionings, namely contraction of muscle and heart muscle. Okay, so calcitonin is going to put it in, parathyroid is going to take it out. Okay, I'm like getting way ahead of myself, but since we're on this microscopic thyroid, I thought it was a good correlation. Okay, so calcitonin is going to be released from those little cells, and they're actually, well, that's good for now. We'll get to it. Okay, so back to the picture. So microscopic. So colloid follicular cells work together to make T3, T4. Any questions on that? Okay, good. So thyroid hormone, T3, T4. T3 is triiodothyronine. T4 is thyroxine. Okay, I'm going to call them T3, T4 because it's just easier. They're produced in that colloid. We're going to use tyrosine, which is actually an amino acid that we'll break down from our foodstuffs. Tyrosine and iodine go in, okay, and they start this really complex process of making T3 and T4, okay. Now, T3 is going to be the biologically active form. So we produce T3, we produce T4, they both go into the bloodstream. As T4 gets closer to a target tissue, it will be converted into T3 because that's the more biologically active form. Okay. So T4, as it gets closer or attached to tissues, turns into T3. So this is going to increase metabolism. It's going to increase anything you could think of: heart rate, blood pressure, increased use of glucose. Okay. The hypothalamus is going to release that thyrotropin releasing hormone, goes to the anterior pituitary, TSH is released, and I think we've got the rest of that. Okay, does that make sense? Okay. So thyroid defects, and where it gets complicated is because we have several steps that can be affected. Okay. So thyroid hypofunction. Obviously, with people with hypofunction, how will they present to us? Are they going to be skinny or obese? Obese. Are they going to be cold or hot? Cold, right? They can get kind of like a roundish face, right? Okay. So people with hypofunction will present that way. Hashimoto's thyroiditis is going to be an inflammation, an autoimmune kind of effect that fights against the thyroid itself, which is going to cause an inflammation of it that decreases the functioning of that thyroid. Okay. What'll happen over time is it'll start to destroy some of that tissue, so you can't release as much T3 and T4. Okay, so Hashimoto's thyroiditis. Goiter can happen. So what's happening with goiter, okay, is you're getting a release of that thyrotropic releasing hormone. You're getting a release of thyroid stimulating hormone. It's getting to the thyroid and it can't make T3, T4. So if you're not releasing levels of T3 and T4 into the blood, we don't have that signal going back up to the hypothalamus to shut it off. The blood or humoral levels of T3 and T4 is what shuts the hypothalamus off in regulation of the thyroid. So you make it in the thyroid, releasing hormone. You make the tropic hormone in the hypothalamus. I'm sorry, in the hypothalamus. You release TSH from the anterior pituitary. It gets to the thyroid. You can't make it, whether it be a lack of iodine or an autoimmune issue. Okay. And it keeps sending that thyroid stimulating hormone, and T3 and T4 are not made to get into the blood to send back to the brain. Can I just check my phone really quick to make sure it's not my sitter? No, it's not. Okay. I'm always afraid it's going to be my sitter. She would just call 911 if there was an issue, though. Okay. And what's going to happen? So you're going to have the precursors of those substances, but they're not combined together, and the colloid starts to grow. You create thyroglobulin, which is one of the precursors to T3 and T4, and it's going to make those areas of colloid grow. And then you get the goiter, okay, the expanded thyroid in the front part of the neck. Does that make sense? Okay. Cholesterol levels can rise is another thing as well. So development of the central nervous system is really, it's the T3 and T4 is really essential for development of the nervous system in a child. So if there's low levels, they can have mental retardation, okay? That'd be cretinism. Mixed edema is going to be an adult. We're going to go through all these and then a little bit more on goiter. Okay, so mixed edema, hypothyroid symptom in an adult, really easily treated though, right? What do they treat this with? Synthroid. Okay, people do really well. Some people, I think they have hypothyroid, right? But now you got to test for the levels. Okay.
Another weight loss strategy.
Another weight loss strategy, that's right. The interesting thing that I did learn when preparing this is there can be a deposition of glycoproteins in the dermis, which will cause kind of that swelling presentation in these patients, that moon faces kind of, well, that's moon faces is with Cushing's, I'm sorry, but they get kind of that swollen presentation. But they can get, have you guys heard about this pre-tibial myxedema? No, okay. For some reason, these glycoproteins, and glycoprotein is what? It sounds like a big word. It's basically a sugar latched onto a protein. Okay, so these are sugar proteins that are put together in the body. And these sugar proteins like to, with people with myxedema, be deposited into the dermis, which is going to be part of the what? We don't, okay. So the dermis is going to be part of the skin. We have 3 layers of the dermis, the epidermis, or the skin, the epidermis, the dermis, and the hypodermis. Do we remember this? Oh, okay, people were kind of looking at me. So the 3 layers of the skin, epidermis, dermis, and hypodermis. Dermis is the thick area, okay, that's going to contain blood vessels and all that. And what will happen is these glycoproteins, for some reason, like to go into the anterior shins. It's called pre-tibial myxedema. I don't know why. Maybe because it's closer to their feet. Maybe gravity drops it down. I don't know why. Okay. Well, there's also a compartment there. But anyway, it likes to deposit into that area. It's called pre-tibial myxedema. So not only do they have that kind of swelling in the face, they'll also have a swelling in the anterior shin. Okay. Kind of interesting little thing. And then this glycoprotein likes to bind water to it. So cretinism is going to be hypothyroidism in a newborn, physical mental retardation, short limbs, obesity, thick protruding tongue. We see a picture of them, and quite often their tongue, it just sticks out because it becomes thickened. Okay. And that's so sad, right? Because once again, that's easily treated, you know. Goiter is going to be that thyroid enlargement, okay? All different types of goiter. Hypothyroidism is going to cause those low levels of T3, T4 we talked about, right? Okay. Body senses this, secretes more TSH, causes the follicles to enlarge. So until we fix either the autoimmune compartment or component or the lack of iodine, this is going to cause a goiter, right? This is going to cause a goiter because the brain's going to keep trying to stimulate it, but they're not releasing T3, T4. So the weird thing about goiter is there can be a hyper or hyposecretion. It gets kind of confusing. So toxic goiter is going to be a hypersecretion. Non-toxic goiter is a hyposecretion. Okay. Diffuse colloidal goiter refers to the increase in the colloid in response to the hypothyroidism that we just talked about, okay, where the colloid will grow. Nodules can form, which is going to be formed with scar tissue, which is sad because that's going to be a permanent thing, right? Okay, Okay, colloidal, if you're going to add iodine or fix the autoimmune component, I keep saying component, it can help the goiter go down, okay? Endemic goiter is going to be the lack of iodine, okay, specifically. So there's different names for them, for different causes. Thyroid dysfunction, hyperthyroidism. So these signs and symptoms will be the opposite, right? People will be very thin. People will have a lot of energy, probably be very nervous, probably be sweating. Okay, anything that you would think of with increased metabolism. I think that's kind of commonsensical. Okay. So remove part of the thyroid if it continues to be a problem. Okay, if there's been some sort of, once again, this could be autoimmune as well. For some reason, their body could be attacking the thyroid and causing an overproduction of that thyroid. Okay, so part of the removal of the thyroid would be part of the fix, or removal of a tumor if the tumor is the issue as well. Okay. Etiology. So cancer would be obvious. Metastasis from the breast and the lung, I think, is kind of common. If you think of it, you know, lymphatically speaking, I think that that would be an easy transition from the breast and the lung to the thyroid. Graves' disease, an autoimmune disease, it's going to cause that hyperplasia, okay? This is interesting. So with Graves' disease, antibodies are created that are similar to thyroid stimulating hormone. But they're stronger than the TSH and they're 10 times more stimulating. So with Graves' disease, these autobodies or autoimmune responses are sent by the body. They stimulate the thyroid, and they also can cause goiter. Okay, so there's different causes to goiter. It gets confusing, doesn't it? So if somebody has goiter, you got to test all sorts of levels and see what's going on. Okay. So they'll attach to the receptors, or 10 times longer. I said 10 times longer, to help create that T3 and T4. Okay. This is what causes exophthalmos. Exophthalmos, do you guys remember? You guys are closer to my age. You're not. You're young. You two are young. But Young Frankenstein, did you guys ever see? What's that guy's name? Not Manny. No, nobody's shaking their head. I gotta stop using these correlations. They're Young Frankenstein, if you've ever watched it, the guy who plays the hunchback in that had exophthalmos. He had Graves' disease, and the eyes are protruding. And I've read different causes as to why the eyes protrude. And the causes are either there's a deposition of fat or fibrous tissue. I read different things in different areas behind the eyeballs. And there's only so much room for your eyeball and your eye socket. So if there is an excess deposition of tissue, be it fat or fibrous tissue, it's going to push them forward and they get that bug eye appearance to the point where their eyes can't close anymore if it continues. Okay, with exophthalmos. I know, it's so sad. Okay. So, thyroid storm, we mentioned that. So post-surgical, a little bit earlier, in response to infection. I think if you play with your thyroid a lot, you can cause a thyroid storm as well. You know, if you keep poking at it, I think you could cause, so don't ever poke at your thyroid, right? Okay, large amounts of T3 and T4, right, would increase high amounts of metabolism, release tons of glucose, tons of fats, okay, probably causing ketoacidosis. We don't want to do this, so don't play with your thyroid. But this can also happen, right, for surgical intervention as well as response to infection. Okay, so I'm done talking. What thyroid dysfunction is this that we just talked about? I hated putting this picture up, but I do think. Oh, cretinism. Yes, this is cretinism. Okay, that thick protruding tongue. This is indeed how they present, with that thick protruding tongue. I know. Isn't this, it's so sad. Short limbs, of course, that's hard to tell with babies, right? I always used to laugh because my boys have such huge heads. They put their arms up and their arms would come to their ears. I'm joking. But, and then as we get older, if you think about kids though, when they straighten their arms only come about to the top of their heads. Did you ever notice that? Yeah. Proportionately? Yeah. Yeah, so I would always straighten their little arms out. And then as we get older, you know, obviously our arms are much higher than our head, but you could see there's stunted growth in the extremities. It's a little difficult to tell because children's proportions are different than ours, but that thick protruding tongue is going to be a definitive sign. What would this be? Pretibial myxedema. You can see there's excessive deposition. You know, obviously other things can create this presentation as well, rash, you know, some sort of infection, whatnot. Usually that'd be unilateral though. But if you see a bilateral presentation of this in somebody's legs, it wouldn't hurt to check thyroid levels now, would it? Okay. Out of what we just went over, what do you think this could be? Myxedema. Okay. This is going to be hypothyroidism. I don't know why they put the normal picture on the right, but
Maybe like the
oh, yeah, I don't think the medication is going to work that well. Maybe it does. That's a good point. Well, let's hope so. Let's hope this one, because he looks like a priest too, so he needs some.
lost a lot of hair.
Yeah, yeah. I just assumed the pre was on the right and they were showing us the post on the left. I can't imagine that the skin would be able to reform back that well. Maybe it could if it was found quickly. That's interesting. I'll have to go back to that website. What? So these are different. They could actually be the same, but these are two separate ones. I couldn't separate the pictures for some reason. Well, I know why, because they're one picture. What do we have on the left? And what do you think caused it, looking at the patient? Marty Feldman. That's the guy who has the exophthalmos. It just popped into my head, and I just gave you the answer. So the person on the right is exophthalmos, and you could see that the eyeballs are pushed forward, so there's some deposition of tissue posterior to that, okay? Marty Feldman, Young Frankenstein. Go look it up on YouTube, okay? And then what's happening on the left, and what do you think the cause of it is? Probably.
Obviously has a goiter.
He obviously has a goiter. God bless you.
Low
Lack of iodine, the endemic goiter. That would be my guess, right? Because he's so young. Okay, good. Any questions on any of those? I know it's crazy what can happen. I hate posting the pictures with kids, but I think pictures are worth 1,000 words. But yeah, it gets me too. It gets me too. Absolutely. So parathyroid are going to be on the posterior of the thyroid gland. They're going to release parathyroid hormone. Okay. Or parathormone, I believe it's also referenced, which is going to release calcium from the bone into the blood, and it's going to balance the calcium between the bones and the blood, right? Because we need calcium in the blood, and if you take no other supplements, take vitamin D, okay? You're not supposed to supplement now with calcium as the rumor, because the supplements are supposed to cause cancer. I don't know. I just get my calcium through food now, is what I do. And I try to do whole food supplements. I don't know, a little off topic there. But anyway, so vitamin D, because vitamin D is going to help with the uptake of calcium from the small intestines. Okay, they're linking vitamin D with so many disease processes. Go get yourself a bottle of vitamin D of good quality on your way home. Give it to you and give it to your kids. Okay, it's just wonderful immune system, anti-carcinogen, helps with bone deposition and absorption into the blood from the GI tract. Okay, so hyperparathyroidism would cause excessive bone loss and would cause depositions of calcium into tissues. Okay, that's called metastatic. It's not cancerous, but it's called metastatic because it's coming from one area and spreading to another. Metastatic calcification. Okay, so you see little depositions of calcium in tissues. I almost said in bone, in tissues that shouldn't be there. I'm trying to remember which tissues are more prone to it, and it's escaping me right now. So I'll think about that. Okay, so parathyroid glands. So pancreas. We know, oh, here's my little pineal gland activator meditation. If you're driving, don't listen to this, turn it off. I'll play it on the next break. So I never heard of this before, pineal meditation. Okay, but well, anyway, I'll get into that a little bit. So the pancreas. Realize, guys, that the pancreas has two major important functions. Well, several, but two groupings of major important functions. Remember we talked about endocrine already, and endocrine is going to be the release of hormones into the blood, right? Obviously, the pancreas is important for this, okay? What are the two hormones which are going to regulate blood sugar? Very good. That's what I was going to ask you about. Glucagon and insulin. We're going to get into this, okay? We all know that insulin is going to facilitate the uptake of glucose into cells. Glucagon helps to release stored forms of sugars and fats for use of energy. We're going to get into that in a little bit. Very good. So that's the general gist. And there's other parts with the endocrine system, but those are the two that we're going to focus on for here. What's the other major function of the pancreas? It's a big one. It's super important. For some reason, it always gets kind of pushed to the wayside. It's actually the majority of the gland. 99%, 98, 99% of the gland does this. Digestive functions. Did you say that? Good for you. Little knuckles. Okay. So digestive functions. Digestive functions. So actually, the majority of the gland is contributed to being an exocrine gland, which secretes major digestive enzymes into the small intestines. Okay. This is the area. Have you ever heard with cystic fibrosis that they have trouble absorbing macronutrients, or carbs, lipids, and proteins? This is where it happens. They oversecrete mucousy fluids that block the duct, that release digestive enzymes from the pancreas. That's what happens. And that's why they have that wasting problem. And that's why they need to have digestive enzymes in their diet to help facilitate that uptake of macronutrients, carbs, lipids, and proteins, okay? So exocrine and endocrine, super important, okay? To know the two parts. Here it is. Here's our little picture, okay? They've got, realize that the stomach guy is superimposed. So the pancreas is going to kind of, nestle right behind the stomach there. The pancreas is in what is called the retroperitoneal space. Do you guys ever use that clinically? I teach you do, okay. Oh, good. See, you guys got to come talk to my freshman students because they look at me like I have 5 heads. So it's in that retroperitoneal space. So if there's an infectious agent in the peritoneal space, it's actually going to be sequestered from that. But we can get retroperitoneal infections as well that can affect this. Okay, good. So I'm glad to know that this is something that people use. The pancreas. So you could see, so there's this stomach. You can trace that first little C shape of the small intestines. That is called the duodenum. The duodenum is the first part of the small intestines. So the anatomical saying to help us remember where the pancreas is that the head of the pancreas sits in the lap of the duodenum. So you can see, just imagine the little duodenum there in a recliner, right? It's sitting in the recliner and it's making a little lap, and the head of the pancreas sits in the lap of the duodenum. And you can see that it goes right across the abdomen then, up into the left or upper quadrant. And its tail, the tail of it, is going to be right next to the spleen, even though they don't show the spleen there. It's kind of weird, but anyway, so the spleen would be right next to it. Okay, so pancreas goes right across there in the retroperitoneal space. Macroscopic. Any questions on that? Cool. Okay. Exocrine and endocrine. So exocrine is going to be digestive. It's about 98% of the bulk of the pancreas. It's going to be made up of what are called acinar cells. And the acinar cells are a grouping of cells that are basically sort of situated almost in a circle per se. And that little circle drains to a duct. And guess what that duct goes to? A bigger duct. And those go to bigger ducts. And eventually it leads out to one big duct, which dumps into the duodenum. And it dumps out enzymes, which will break down carbohydrates and proteins and lipids. Okay? So even though we're not on digestive yet, I think that's an important thing to sort of think about. The endocrine portion are going to be, you'll see if you're looking at a microscopic, we have a microscopic picture. Okay, that grouping of cells, you don't need to know the difference visually between alpha and beta cells. I can't figure out the difference, to be honest with you, and I've read a couple different tutorials about it. Alpha and beta cells in the pancreas. Those alpha and beta cells are being grouped in little islands called islets of Langerhans, okay? And so you'll see them interspersed throughout the pancreatic tissue. Now, the alpha cells are going to release glucagon, and glucagon will help to release stored forms of glucose and fats. Okay. Glucagon is going to help to release stored forms of glucose and fat. Insulin is going to facilitate the uptake of glucose into cells. Okay, we talked about that a couple of slides before. Okay, these alpha and beta cells will be grouped in the islets of Langerhans. Any questions about that? Cool. Okay, moving on up. Oh, here we go. Okay, so insulin is going to put the glucose into cells. Insulin is not needed for all the cells of the body, though, interestingly enough. It's going to be needed for skeletal and cardiac muscle, okay, adipose connective tissue. Not needed for brain, liver, and red blood cells, which kind of makes sense because we need a constant supply of glucose going into those cells. We have what's called glucose sparing. We will save all the free glucose in the body. Could you shut that door for me? There'll probably be, thank you so much. I'll wait until you're, okay. The brain needs a constant supply of glucose. Okay, so we'll spare all the glucose necessary for the brain for it to thank you so much. Okay, but in these tissues, we need quick absorption of glucose so we can send it out to the rest of the body. Okay. So it's not, so what that statement, I had to reread that statement, I'm sorry. It's not needed for the brain, liver, and blood cells, but even though it's not needed for the deposition of glucose into liver cells, it helps the breakdown of glycogen. Do you guys remember what glycogen is? Okay, let's do a quick little review here. So people at home, I'm going to bring you up, because I think we need to understand these mechanisms really quick. Oh, we're going into metabolism. Lordy. So we eat foodstuffs that can be broken down to glucose, all different types of foodstuffs. You know, we've got sugars, complex carbohydrates, you know, simple carbohydrates, whatever they may be. When we ingest them, our body will break them down into simple units of glucose, okay? And then that glucose will be put into the bloodstream, also known as dextrose. And what our body does is we'll take the glucose from the small intestines and absorb it and send it to the liver. At that point, the liver determines whether it goes into the bloodstream, whether it stores it in the liver, right, or whether it makes fats from it. So, well, the liver contributes to that process, okay? So if we store glucose, guys, what is it stored as? Glycogen. Okay, so the first job of glucose in the bloodstream is to be used as energy. We'll send it into the bloodstream. It'll be put into all the different tissues, either with insulin or without, is what we talked about before. If we use all the glucose that we need, the next step is we'll store it as glycogen. Okay. So glycogen is stored glucose. It's simply stored glucose. Okay. Glucose has this little six-sided figure or shape to it. Okay, it can also be five-sided, but we'll go six-sided. And it'll take these little round structures of glucose and chain them together, okay, in bonds. We'll do this in the skeletal muscle and the liver. Okay. So glycogen. So glucose comes in, we use the glucose initially for energy, and then we bond it in these long chains of glycogen, okay, for food, if there's extra glucose used over. So if we eat a really big meal and we have used the glucose, and now we've stored the glycogen and we still have leftover glucose, then we make fats, okay? Then we make fats. So 1, 2, 3. And this glucose can actually be converted into fats. Okay. Are you with me? Okay. Okay. Then if we move into low glucose levels, we'll start to tap into glycogen and fats, okay? Okay, so insulin helps this process of storage. Glucagon is going to reverse it and take out the stored fats and the glycogens, okay? So that's that statement, but it's needed for glycogenesis, okay? Genesis was what? Don't let these words scare you. I'm going to make it so easy. Genesis, the book of Genesis in the Bible, is the creation of the world. So if I say we're doing glycogenesis, it's the creation of what? Glycogen. If I tell you we're doing lipogenesis, it's the creation of stored fats. Okay? Lysis is the breakdown of. Lipolysis is going to be the breakdown of fats. Glycogenolysis is going to be the breakdown of glycogen. Okay? So glycogenesis in the liver is facilitate with insulin. That's what that huge statement is about. Okay? It's going to be the stored form of glycogen. Now we store glycogen once again in the liver and the skeletal muscles, but skeletal muscles are really, really greedy. They're going to use the stored forms of glucose for themselves. Liver shares. So if we have systemically low levels of glucose, where we're going to raise those blood levels is going to be the liver. Okay? Okay. Yes? Okay, good. So glucose levels is going to start that opposite process. Releasing stored glucose that's stored as glycogen, releasing fat. Okay, glucagon is going to affect that. We're going to have glycogenolysis, the release of glucose from stored glycogen, gluconeogenesis. Okay, so this is going to be if somebody's going into a period of starvation, gluconeogenesis. Once again, don't let it scare you. Genesis is the creation of, okay? Glucose is glucose. Neo is what as a prefix? Neo is new. Gluconeogenesis, the creation of new glucose. So we can take fats and we could take proteins in the periods of starvation and use them to actually create new glucose to feed into our energy systems, gluconeogenesis. We don't want to do that though. Well, with fats we do, but if we really go into starvation, what are we going to tap into for energy? We're going to start to tap into your proteins. And that's where you start to see that muscle wasting. And that's where we see that gluconeogenesis being a problem. For many reasons, because protein's very inefficient as a source of energy. Okay, but it's also not good to eat away at your body structures as well. That's not a good thing. Okay, so insulin and glucose, that's a chunk of change. Are we okay with that? Okay, okay. Anybody at home? I'll check my messages on the break. So diabetes mellitus. Let's take a break here. How's that sound? To break it up a little bit, okay? Because that's going to be 10 or 15 minutes on diabetes easily. Okay, so I'm going to stop the tape, take a little 5-minute break, and we'll restart it. I'll check my emails too. Okay. I'll give you your pineal gland meditation.